When you hear AI in healthcare, you probably picture a faster diagnosis or a cure arriving sooner. That is the brochure. The reality already hitting your bank account is quieter and less flattering. Artificial intelligence is being used right now to decide what your insurance will pay for, how fast your claim gets denied, and how hard it is to fight back. We followed the money. Here's the receipt. Start where it touches you first, the claim. Before AI, a human being at your insurance company reviewed whether a treatment was covered. Increasingly, that first decision is made by software, and the doctors treating you have noticed. In a 2024 survey of 1,000 practicing physicians, the American Medical Association found that 61% are concerned that artificial intelligence is increasing prior authorization denials. 74% said denials have gone up over the past 5 years. 93% of those physicians said prior authorization delays care, and 82% said it sometimes leads patients to simply abandon treatment they were prescribed. The denial is not abstract. It changes what care people actually get. Here is the most cited example. United Health, the largest health insurer in the country, used an AI tool called Predict to help decide how long Medicare Advantage patients could stay in rehabilitation and nursing care. A class action lawsuit alleges that tool had roughly a 90% error rate, meaning when patients appealed, about 9 out of 10 of those denials were reversed. United Health says the tool informs rather than decides coverage, and a federal judge has ordered the company to hand over its records. It is not just one company. ProPublica reported that Cigna used an algorithm called PXDX to deny around 300,000 claims in a 2-month stretch in 2022, spending an average of 1.2 seconds reviewing each one. One company doctor reportedly signed off on roughly 60,000 denials in a single month. That is not review. That is a rubber stamp moving at machine speed. In 2024, a United States Senate subcommittee investigated and found that United Healthcare more than doubled its denial rate for care after hospital stays between 2020 and 2022 after deploying that AI tool. Humana's denial rate for similar care grew 54%, and the documents showed why. One insurer projected that its AI denial tool could save $77 million over 3 years. The savings come from saying no, faster. Here is the caveat, because this is a credibility channel. The insurers maintain these tools assist human reviewers rather than replace them, and the 90% error figure comes from a lawsuit complaint, not a final court ruling. Some prior authorization AI vendors report high satisfaction from the doctors who use them. That is fair to name, but the pattern in the data, denials up, speed up, savings projected from refusal, is consistent across multiple companies and one Senate investigation. Now follow the money around the invoice, because this is where it gets strange. The same kind of AI is being sold to the insurer to deny your claim, and to the hospital to fight that denial. Both sides are buying weapons in the same arms race, and you are paying for both. When a claim is denied, you often do not fight it. On Affordable Care Act marketplace plans in 2023, about 20% of in-network claims were denied. Patients appealed fewer than 1% of those denials. That is the quiet engine of the whole system. When denials are fought, more than half, about 54%, get overturned. The denials are frequently wrong. They stick anyway because almost nobody appeals. The hospitals do fight, and it is expensive. Chasing down denied claims costs American hospitals nearly $20 billion a year. The average cost just to contest a single denied claim is about $44 in administrative labor. That cost does not vanish. It gets baked into the price of care, which gets baked into your premium. The arms race upstream becomes a number on your bill downstream. So who is selling the software on both sides? A growing industry. The AI medical billing market was about $4.7 billion in 2025, and the broader market for AI in revenue cycle management, the business of getting claims paid, was about $25 billion. In 2025, roughly 80% of U.S. health systems were exploring or deploying AI for billing and claims, a 38% jump in 2 years. The vendors win no matter which side wins. And then there is the newest wrinkle, the one most people have not heard about. As of January 1st, 2026, traditional Medicare, not a private insurer, the government program itself, began using AI-assisted prior authorization for the first time at scale. It is a 6-year pilot called the WISER model, running in 6 states: Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington. The contractors running the AI review are paid based on the savings they generate. Critics point out the obvious. When a company is paid more for finding reasons to say no, the incentive is built into the contract. The caveat: CMS says final denials still require a human clinician, and the model targets services it considers prone to overuse. The other caveat matters too. A hospital using AI to overturn a wrongful denial is, arguably, working for the patient. The same technology cuts both ways depending on who is holding it. But the money to buy the best AI is concentrated on the side that benefits from denial. United Health Group, the company at the center of the leading lawsuit, posted $400 billion in revenue and $14.4 billion in profit in 2024. Now, the part of the brochure that is actually real, and the question that matters for your wallet. AI genuinely is making parts of medicine faster and cheaper to produce. In drug discovery, AI is projected to cut preclinical research and development costs by 25 to 50%. And analysts estimate it could unlock somewhere between $75 and $110 billion in value across the pharmaceutical industry. In January 2026, NVIDIA and Eli Lilly announced a roughly $1 billion AI factory dedicated to speeding up drug discovery. The capital is real. The acceleration is real. Here is the question the brochure never answers. Does any of that saving reach you at the pharmacy counter? So far, there is no published evidence that it does. The savings accrue to the manufacturer. Drug prices in the United States are set by a long chain of negotiation, rebates, and patents that AI efficiency does not automatically touch. A cheaper molecule to discover is not the same as a cheaper prescription to fill. The same logic applies to AI diagnostics. Faster reads and earlier detection can be genuinely good medicine. But a faster scan does not lower the bill if the facility fee, the radiologist charge, and the insurance markup stay the same. Step back and look at what a household already carries. The total cost of healthcare for a typical American family of 4 on an employer plan reached $35,119 in 2025. That number has nearly tripled in 20 years. AI now sits on both sides of that number, speeding up the denials that raise your out-of-pocket costs and promising savings upstream that have not yet flowed downstream. The technology is moving fast. The price relief for now is not. Here is the receipt. 61% of physicians say AI is increasing prior authorization denials, and 74% say denials have climbed over 5 years. United Health's tool is alleged to have had a 90% error rate. Cigna's algorithm denied 300,000 claims in 2 months at 1.2 seconds each. Patients appeal fewer than 1% of denials, even though more than half of the ones that are fought get overturned. As of January 2026, traditional Medicare itself added AI prior authorization in 6 states, and a family of 4 already pays $35,000 a year. The AI in your healthcare, right now, is mostly pointed at the bill, not at lowering it for you. We will keep pulling the receipts, the numbers behind the noise. So what do you actually do with all of this? 4 moves, straight from the data. 1. Appeal. This is the single highest value action in the entire system. More than half of denied claims that are fought get overturned, and yet fewer than 1% of patients appeal. If a claim is denied, ask in writing whether an automated tool was involved and file the appeal. 2. Get the denial reason in writing and ask for the human. Insurers increasingly must disclose when automated tools are used. Request the specific clinical reason and the credentials of the reviewer. A denial generated in 1.2 seconds does not survive a careful written challenge as well as it survives silence. 3. Separate the promise from the price. When you hear AI will make medicine cheaper, ask cheaper for whom, because there is no evidence yet it has lowered what patients pay. And 4. If you are on traditional Medicare in Arizona, New Jersey, Ohio, Oklahoma, Texas, or Washington, know that AI prior authorization now applies to certain procedures in 2026. Want the full receipt? Every number, every source. It is on our Substack, and the link is on our channel. If the data matters to you, subscribe. We will have the next receipt ready.